we have 15 minutes for a panel discussion with our three speakers. I might start with a question for Michael. So Michael, you presented some pretty compelling evidence on the impact of vaccines on some very common chronic illnesses. Have there been health economic studies for us to see, the cost-benefit analyses essentially for giving these vaccines more broadly and maybe reducing the age eligibility for funded vaccines?
There's certainly been modelling, and this is the job of the people who put the submission to the PBAC for some of these vaccines. There's been modelling. Whether we've got real-life evidence of some of these off-target benefits, both reducing in prevalence and potentially being cost-saving, I don't know. Maybe other people in the audience can answer that question better than I. I would like to see less stroke, less heart disease and less dementia over the next 20 years. I'm not sure that we're going to be able to easily show that's due to vaccination because there's many other moving parts. In the area of dementia, people are improving with their lifestyle, and we now do have drugs that might eventually be used to prevent dementia. Immunotherapy that I've just showed you is not being just used for people with signs of dementia. It's being used with people who already have amyloid accumulation but before any symptoms at all. So we might have a new era that's driven by that rather than by vaccination. But it's a good question.
Great. So lots of work to be done still in that space.
And I'm sure it's being done.
And then Sarah, yesterday we had a really nice presentation from Beck, the pharmacist, about pharmacy-delivered vaccines, including, the more recent move towards travel vaccines. So in your presentation, clearly it's quite complex. It's not a simple recommendation, and there are lots of considerations. And in addition to vaccines, as you well know, there are lots of other discussions during travel consultations, traveller's diarrhoea, altitude sickness, etc. So what do you see as challenges and opportunities for pharmacy-delivered travel vaccines? And also, are there specific populations where you would recommend that the pharmacists send their patients to a specialist travel clinic?
Yeah. Thanks, Colleen, for the question. Look, I think we're preaching to the converted here. Vaccination is everyone's business, and I think I'm very much pro any expansion of vaccination, in the sense that I think the more places that people can get vaccinated, the more places they can have conversations, the more vaccine uptake we're going to get. As with anything, travel medicine has its challenges in terms of delivering a comprehensive consult in a short space of time, and that's regardless of which kind of practice setting you sit in. I think I have a specialist clinic. I get half an hour with a patient, and that's not often a luxury that people who are seeing people in community practice get. I think that every state is tackling this slightly differently. I can only really speak from the Victorian perspective. I've been somewhat involved in giving advice to government and also working with Monash pharmacy faculty to actually develop some of the training materials for pharmacists who are expanding their practice in Victoria. And I think, generally speaking, we would recommend that if there are complex itineraries, complex vaccination needs, vaccines that are outside of pharmacist scope, that they refer on to another provider. But there are certainly many vaccines, including NIP vaccines, including things like hepatitis A and typhoid, that can be given at a pharmacy level. And I think if a patient is seeing their pharmacist and there's the opportunity to give them those vaccines, then I'm all for trying to opportunistically vaccinate travellers, because we know most of them don't make it to a specialist clinic. I think the challenges are going to be the national harmonisation of what's happening. So every state's started slightly differently, and there are still vaccines that are out of scope. But I know that there is work being done on improving that.
Great, thanks, Sarah. And just maybe a question for Jamie before I open up to the floor. So really exciting, Jamie, to see all the different vaccines that are in various phases of clinical trials. When do you think we're likely to get a new TB vaccine, and do you think it's more likely to be one that prevents disease or infection or recurrence?
Well, I think the outcomes, so as I mentioned, there's a lot of interest in this M72 vaccine. we'll probably have data on that in about 3 to 4 years. There's still vaccines coming into the pipeline. I think that, look, I think that we will be looking at a vaccine that prevents disease. I think that's where most people feel is the most critical parameter. If something will, I guess the limitation in terms of timing is something comes up from early clinical data in the next few years, you're still going to have 5, 6, 7 years to see an outcome. If in the meantime, there are people now developing human challenge models for tuberculosis. So I think if in the meantime we might have better models to be able to determine how effective a vaccine may be in humans, maybe we could use a shorter trial that we look at different parameters. So hard to say, but we're certainly at least 5 years away.
Okay.
Could I just make a comment on what Michael was talking about?
Yes,
Because
of course.
I think this issue around for example, the reduction in dementia, I think is fascinating. And of course, there's a lot of negativity and misinformation around the proposed risks and issues with vaccines. This is a really good news story. So do we now need people are obsessed with longevity. There's a massive longevity industry worth billions of dollars where people are taking alternative medicine. Do we need a really compelling social media campaign for the benefits of vaccines in making you smarter and living longer? I just think it'll be a great thing, but if we have the evidence for that,
That's fabulous. I'm not a social media person. I want to, and if it was, I'd never get into America. But I think we do. I think we do. We need to actually counter. We're trying hard to get rid of vaccine hesitancy and misinformation, but maybe we can neutralise it. As I said, the first few words of my talk, this might be a way to sell vaccines. It prevents dementia.
Thanks, Michael. So, questions from the floor?
He's got the microphone. Oh, I've got the microphone. So, Sarah, question for you. With travel advice, obviously, these are about our citizens going overseas. What's the flow like the other way? What vaccines are required to come into Australia from where? Which is a big question, perhaps, but maybe the real question is there a case for us to require MMR vaccination for people from endemic areas?
Yeah, sure. That's a really great question. I think we're thinking more about different directions of travel. Travel medicine has traditionally always been about people from high-income countries going to lower middle-income countries, but that's changing. And I think there's as much risk now of measles being exported from high-income countries to lower middle-income countries too. The reality is it depends on the visa type or the entry type. So the only populations in which screening or vaccination is required would be people who are having specific types of visas. So that might be working visas or it might be humanitarian entrance and so on. As far as I'm aware, there are no vaccine requirements for people coming in for any other purpose. I think it gets challenging. We've seen a lot of pushback against vaccine mandates. Yellow fever vaccination certainly has its issues as well, and that's something that the countries where yellow fever is a risk, they grapple with all the time. There's issue with falsification of vaccine certificates and so on. But I think really just promoting vaccination and making travellers aware of the fact that they may pose a risk not only to themselves but to the communities that they're visiting and to the communities they're coming home with, I think is another one of these benefits of vaccination, that peace of mind that you're reducing the risk of transmitting diseases to others as well. Although unfortunately not everyone is as socially minded as those of us in the room. But yeah, I think that's the way I would pitch it.
Thank you, Sarah.
Hi, good morning, everyone. So I'm Julius. I work as a nurse immunizer and also an after-hours coordinator in aged care. This question is directed to Professor Michael. Lovely presentation, by the way, and it's really an eye-opener. So one line struck me the most. Specialists, primary health care most actively promote vaccination. How about the aged care sector? Any inputs or comments regarding uptake with vaccination and the link with dementia? Thank you.
There's a terrible rate of vaccination in aged care, despite the initiative we saw in Victoria earlier today. We've got to Look, I'll tell you what, one of my children, I won't dob her in, but said, well, we shouldn't have all been locked down under COVID because it was only killing people in nursing homes. That was her comments. That's the attitude of some older people to residential aged care, even in, unfortunately, my own family. So we've got to turn this around. We've got to have, there are a range of strategies. Paul's going to talk about them at the masterclass that I mentioned to try and increase vaccination rates in aged care. We've got to do better. I think there should be almost an opt-out rather than opt-in, but there are all sorts of issues around legality and side effects and what have you. But yeah, I agree. Aged care, we need to have a better way of getting more vaccines in arms. Unfortunately, preventing dementia in aged care is the horse has already bolted because 80% of people have already got it. But maybe vaccination reduces the rate of progression, maybe. And just a quick comment about the social media. I just thought, how many health food shops have got so many things on their shelves to prevent Alzheimer's disease? Maybe they need to have a vaccination stand in health food shops.
Thanks, Michael. There's a question for Jamie from somebody online, from Jennifer Thompson. So she says, if it's difficult to determine or select a particular antigen for a good immune response, is it possible to take a different approach and attach an immunogenic molecule to MTB to facilitate recognition and immunity?
Yes. We've tried that. I guess we've done not so much MTB, but there's been a lot of work on modifying BCG, the current vaccine, and make that more immunogenic. And as I mentioned, that's one of the vaccines that are currently in phase 3, although data doesn't look great. The interesting thing about that, and we heard about this in the off-target effects of BCG. BCG is a strange beast. It does some unusual things. It's an incredibly consistent and protective vaccine in animals, so it's your benchmark in animals, but we know it's not that great in protecting adults and adolescents against disease in humans. So yes, you can certainly modify mycobacteria, not so much the bug, the TB, but BCG. You can see some outstanding effects in animal studies, but it hasn't seemed to have translated to an impact in humans.
Okay. So while we're on BCGs, it's not a perfect vaccine, but it's all we have at the moment and probably for a few more years to come. And as Sarah mentioned earlier, it's something that we should consider for young children travelling to high endemic areas. However, access to BCG for young children in Australia is very challenging at the moment. We did a study in our travel clinic, Dr. Deborah Mills' travel clinic in Brisbane recently, showing that sometimes, families have to wait up to a year in the public system. And of course, usually they're travelling before that. And in the private system, there's limited access, very expensive. So what can we do to try and improve the situation? I mean, there might be others in the room who might want to comment on that as well.
Want to comment on that?
Yeah, look, I mean, it's a very difficult thing. I'm not a paediatrician, so I'm probably not the best qualified to answer, but certainly there are services in the public system that offer vaccination, but generally they're limited to either offering to 12 months or younger, or the highest priority infants. So I think for parents it's really about trying to find a private centre that does it if they can't get into the public system. But Christine might want to comment. Yeah.
I wanted to thank all of the speakers first for a fantastic session, because it's really been great to hear all of the rich information you presented. And I think on BCG, Colleen, noting your really important recent paper and noting the discussions around a national immunisation strategy, it's a vaccine that is underutilised in Australia. Having been involved in some cases where children who travelled, whose parents were seeking a vaccine, and those young children came back with devastating, life-limiting, neurologic consequences of TB, meningitis. It's just heartbreaking to see that. So it's a vaccine that we should increase access to. We don't even have a fully registered vaccine in Australia, and we have a patchwork. So as another thing to put under our wish list for the National Immunisation Strategy, I think it's there.
Thank you, Christine.
Yeah, just a quick comment. One of the interesting things during COVID was that there was globally, historically there's been shortages of BCG just in terms of manufacture, and during COVID, when there was a lot of work looking at potentially using BCG as a way of protecting against COVID, there was concerns about supply of BCG being taken up for those studies and not being available to young children, because although my talk, I paint a picture of BCG in a negative sense, that it's clear that, as mentioned, it's very good at protecting young children against complications of TB. It just doesn't work very well in adults. So it is certainly an important childhood vaccine to have.
Thanks, Jamie. So one last question before we go for lunch, and we can continue discussions during lunch.
Hi. Probably the reason why BCG is so difficult to have, it is a difficult skill set in order to do, and you have to have a certain skill set in order to do it, and to do it effectively and properly. But my question to you is, in outback Australia, there's a number of Hansen's diseases. Okay, so I'm just and we used to have to give the babies of previous Hansen's families BCGs, and apparently we were told it was about 50% effective. Is your new vaccine going to be effective against Hansen's disease?
Okay, so Hansen's disease, leprosy, yeah. Well, it depends on the vaccine. So the modified BCG, depending on what happens there, yes, because there is that crossover protection between BCG that can protect against tuberculosis to some extent and potentially leprosy. The other vaccines will depend on the antigenic makeup and how similar they are to what are in the other mycobacteria. I think those antigens, so the most advanced vaccine is 2 antigens together. I think they are conserved across the mycobacteria, so possibly, but it hasn't been tested for that indication. So it'd be interesting to see if you would necessarily, once approved for TB, I don't know if it would necessarily be approved for other conditions that would have to be tested in that setting. So possibly, but unclear at this stage.
Great. So big thank you to our 3 speakers for the great presentations and discussions, and also thanks to the audience for your participation.